what kind of cardiologist are you? So I said, transplant cardiologist, take care of heart transplant patients. And there was a period of a few minutes of silence, and she said, you know, my brother was in an accident and became a donor and donated his heart and some other organs on a particular date. And I thought about it and actually realized, because I'd been involved in that particular recipient, that her brother's heart had gone to one of our patients down in the temple. So you never know where you're going to hear things. And the other one is a little bit lighter story. My car stalled on Friday. It's always an inconvenient place. So, you know, I called the place to repair the car, and then call the towing people, and they say, what's your name? And I say, Dr. Eisen. I say, yeah, Dr. Eisen. Didn't work at Hahnemann. Started to take them to Erie. And it was the sister of one of the transplant patients. So I don't know how the tow truck came out there. He must have broken all sorts of laws, but he was never going to Is this great or what? So anyway, I'd like to thank all of you for inviting me. This is going to be very extemporaneous, which means I didn't prepare any fancy medical slides or anything like that. I'm just going to kind of tell you where I think organ transplantation, and at least in my field, treatment of advanced heart failure is going in the next 20 years. Dr. I was told Dr. Franzio provided me with some guidelines here of what I should talk about, but I'll talk about a few other things also. Just a little bit of background about me. I was trained in taking care of heart transplant patients back in the mid-'80s. So that was when heart transplantation really started to reemerge. Some of you may remember it first appeared in 1967. Richard Barnard did first transplant. Actually, Mr. Mead is married to the original heart transplant coordinator in the United States. His wife worked for Adrian Kantrowitz, who was the first person to do a transplant in the United States, and that was about 2 weeks after Christian Barnard. And the problem was, back then, the surgery was relatively easily perfected. You know, surgeons hate to hear this sort of thing, but what they did was actually relatively simple. But the job of preventing rejection was very, very difficult. In fact, nobody even understood how rejection developed. And the people who ultimately got the Nobel Prize a few years back for work they did to figure out how cells reject organs, they didn't really start doing their research until the early 70s. Didn't really figure it out until the mid-70s. So it was about 7 or 8 years after heart transplantation it started. So as a result, the outcomes were not great, and the number of transplants almost disappeared. The number of transplant centers almost disappeared. By the late 70s, there were maybe 50 transplants being done in the United States, most of them at Stanford, a few Medical College of Virginia and Richmond, a few in Columbia, New York. And then in the early 80s, cyclosporin appeared. And cyclosporin was kind of a revolution in that it prevented rejection, whereas there were no other drugs that could do that. Did a better job of preventing rejection, and even if you had got rejection, didn't have rejection that was so severe that you'd lose your organ. It used to be, before cyclosporin, that if you got rejection, it was kind of like a countdown. You had 24 hours to reverse the rejection, and if you didn't, you lost the organ, and if it was a heart, you lost your life. So it was pretty difficult time. So when cyclosporin appeared, all of a sudden the number of transplants increased, the number of transplant centers increased. There were a few bumps along the road. Whenever a new medicine appears, people don't even know exactly how to use it, but there tends to be a little bit of over-exuberance, so people used a lot of cyclosporin and quickly realized what the side effects were. I was fortunate in my training that I was in one of the first places that did something called triple therapy, which is where you use a little bit of cyclosporin, a little bit of corticosteroids, and a little bit of, back then it was immunoregulated thioprin. And that seemed to work pretty well, and we used biopsies to make a diagnosis of rejection. Rejection was still a big issue, but not nearly as big an issue. Infection initially was a very, very big issue, although there were new medications that came out to prevent infections. So, and interestingly enough, a lot of the infections that were seen in the HIV patients were really seen for the very first time years before that in transplant patients. And these infections back in the early era could be absolutely lethal. When I started my internship in the early 80s, the very first patient that I saw was a kidney transplant patient who was on these very high doses of steroids and other things, and not cyclosporin, which didn't exist then. And so was very immunosuppressed and had CMV. Anybody have CMV? Ever have CMV? Back then, a lot of people have CMV. Back then, CMV was a death sentence. There were no antibiotics or antivirals, and the poor young woman who was about 18 passed away as a result of CMV. So in the 90s, there were developments that really led to the improvement of ways of preventing infection. CMV was one of them. First intravenous medicines like acyclovir. Anybody remember going home when I began acyclovir? You guys were too early, because now there's an oral pill people can take and they don't have to get the Hickman catheter. Seems artsy. Yeah, you have to do it again. The people at Penn will be very happy to do it. I'm not going to give them my cell phone. So. Pneumocystis was another one, a very dangerous bacteria that was seen in HIV patients, but was first seen in transplant patients. Interestingly enough, way back in the past, when I was at Penn, which is kind of where I started out after my training, we were among the first to use Bactrim as what's called a prophylaxis to prevent people from getting pneumocystis. We kind of figured, well, you can give a little bit of this and see if it prevents. And the HIV people were doing it. Sure enough, we never saw another case of PCP, except in those people who stopped taking Bactrim. But we don't see very much PCP at all. We don't see much CMV. The infections that we do see now are hospital infections. And in a way, those are a little bit more difficult because we've been, we being the collective we, the medical profession, has been using antibiotics pretty indiscriminately. And as a result, we have bacteria that are resistant to just about everything. So even my colleagues from Hahnemann here, they know that I'm a fanatic about not giving antibiotics unless there's a diagnosis to treat. But I remember a few years back, there was a patient of ours who was already very sick, but got incredibly sick with a bacterial infection. And it was sensitive only to a drug that I didn't even realize they made anymore because it was considered obsolete when I was in medical school. That was a while ago, so it was 1970s, early 80s. And they kept it in reserve just to treat this bacteria. And that was all that would stop it. So those are the challenges that we face in terms of infection. The good news is that there are ways of preventing infections, simple ways in terms of putting in proper ways of putting in catheters, proper ways of putting in Foley's or not putting in Foley catheters. One of the most interesting things, which I found interesting, and it was in one of the medical magazines that I read pretty frequently, which is the New Yorker. You ever read the New Yorker? The New Yorker is pretty good. So now check this out. There was a physician at Johns Hopkins who was one day getting onto an airplane, and he just happened to look into the cockpit and saw these guys, pilots, checking off the checklist. And he thought, and he subsequently got a Genius Award. This is a genius thing. He said, now why don't we do that in medicine? So sure enough, he developed some checklists for the operating room, checklists for putting in central lines, and dramatically decreased the infection rate, intraoperative infection rate, line infections, and that's really become the standard. So, I mean, sometimes it's not even the most advanced antibiotics, but it's just simple things like good sterile techniques. But I think that we need to be vigilant about infections, but there are ways, non-sort of scientific ways, more common sense ways that we can prevent them. Now let's talk about rejection. Everybody had their rejection at some point? Yeah, show off.
You know it.
Yeah, I know, you've had everything else, but no rejection. You had to get rejection or you get into an auto accident in Kentucky taking care. So rejection used to be it used to be a feared complication. Feared before cyclosporin, a little bit less feared, but still very significant because we didn't have great ways of treating it. We have better ways of treating it now. We have better drugs for preventing it. The way that we make the diagnosis in heart transplant up until very recently has been doing endomyocardial biopsy, and I'll talk about that in a few minutes. But I think some of the really exciting things, some of the new immunosuppressive agents that are out there, some are approved in other countries. The FDA wants to make sure these drugs are safe in animals and then in Europeans before they decide to let them come over here. So we'll wait and see what the experience is in Europe. But some of these drugs are pretty amazing. They're One was everolimus. Not everybody agrees that it's an amazing drug, but I think it is. And it's similar to sirolimus. But these drugs have and they do come with side effects. So the problem with transplant, as everybody knows, is that all these things are two-edged swords. But these drugs have the ability to stop the immune cells from expanding and stop other cells from expanding as well. So what cells am I talking about? I'm talking about the cells that are in the walls of the arteries of the heart or kidney or other organs. And over periods of time after transplant, those can be damaged and can narrow, can damage the organ. There's evidence that these drugs can actually prevent that or reduce the severity, which is pretty significant because we've tried all sorts of things and nothing has really worked. There's also evidence that these drugs can reduce the likelihood of developing cancer or malignancies after transplant. And in fact, the drugs are being used as adjuvant therapy in cancer patients, non-transplant patients who have cancer. And the reason is because they prevent cells from dividing. They have a name. They're called the mTOR inhibitors. mTOR stands for mammalian target of rapamycin protein. It turns out it's a crucial protein in how cells divide. And the ordinary in cancer, what happens is the proteins that act as brakes on this mTOR are mutated and don't work. So the cells are free to proliferate wildly. And giving drugs like mTOR, they suppress this protein and suppress the growth of these cells. Has anybody ever had a stent put in their arteries? Leak off? Are you nodding your head? Yes? Okay, good. I know that. I know you did. That's why I want you to You've heard about these drug-eluting stents, and they use the same kind of drugs. So what happens with a drug-eluting stent is that first you put in, and you think about it, it's pretty amazing that we get away with this as cardiologists. And when I first heard that people were going to do this when I was an intern, it's like a brand new technique. I think you could do what? You could open up a balloon, somebody's artery. Wow. So anyway, they open up a balloon in somebody's artery to push apart the blockage. And nowadays, to prevent the blockage from redeveloping, they put in a stent, which is like a mesh. The problem with that, when they use the old types of stents, is that it would cause injury to the arteries. And what happens to injury is that the body tries to heal itself by making scar. Scar is nothing but a bunch of cells that divide and produce the scar. So with the old-fashioned stents, what are called bare metal stents, people would get narrowing in the arteries. With the newer stents that release this protein, one of these mTOR inhibitors, in this case sirolimus or rapamycin, that prevents these cells from developing. So that's why you don't get these blockages. In heart transplantations or other organ transplants, there is also ongoing injury to the transplants. We don't know exactly what the injury is. There's numerous things. But some people develop narrowing of their arteries, for example, in heart transplantation. In that case, we try, and that's a response to injury, we try to block that. In that case, we do it just by giving people medicines by mouth, so it goes systemically, and seems to work pretty well. So I think we've got some pretty interesting immunosuppressive agents. Kidney transplant, who's kidney transplant? Okay. Who's a kidney transplant? The lung. You and you, right? So because there are more kidney transplants, there's actually a little bit more research being done in kidney transplantation. So there's some other interesting drugs that are, or medications that are out there. And there's another thing that's being studied. Has anybody ever heard of the term tolerance? Tolerance. Okay. What does it mean?
Tolerance is a situation where the body is tuned to accept the organ and the organ to accept the body. And eventually the idea is to wind up with no immunodrugs needed.
Right. So that's right.
Things happen a lot more with liver than anything else.
Yeah, so as many as a third of liver patients in some studies end up not needing immunosuppressive agents. And the liver is kind of a different organ. It's a big organ. It regenerates itself very quickly. And it seems to produce proteins that fool the immune system. So liver transplant patients can get off of immunosuppression or very little immunosuppression. Heart and kidney, who's a liver transplant recipient? Are you on immunosuppression?
Yeah, it's no good.
There you go. So not very much. So the liver is almost immunoprivileged, is what they say, but the heart and the kidney and the lungs certainly are not. There have been some interesting studies trying to figure out why people are tolerant. If you look at the patients who are tolerant, they're usually what are called, you spoke about survivors. These are survivors. So these are people who stopped their immunosuppression. So they're kind of bad boys and girls of transplantation. And the ones who didn't get into trouble are the ones who are tolerant. I'm not recommending anybody do this. This is, this is an example of better lucky than good. So people are trying to figure out exactly why tolerance occurs, and there are a number of papers that have appeared in medical journals. Later this year in the New England Journal of Medicine, there may be some papers that might explain this further. The problem with tolerance, as it turns out, is that it's unstable. So it's not as if you reach tolerance and you're done, you don't need immunosuppression unless you're a kidney transplant, unless liver transplant. If you're kidney or heart transplantation, you can be tolerant at one point and then not be tolerant at the other point and need immunosuppression. So it's very complicated and actually very dangerous. At this point in heart transplantation, our goal is not so much to achieve tolerance, because we don't really know how to do that. And even if we do it, we don't know how to stay there. It's to try to get people on the appropriate immunosuppression and try to then wean the doses down to the lowest possible dose. And I'm going to let you in on maybe it's not a secret, but it might be a secret, which is that for years, true confession, we have been over-treating all of you with immunosuppression. So all of your suspicions about, those doctors are giving me too much medication, absolutely true, in most cases. Doris, I don't know what to say, but I'm sure you ever needed those and so why do I say that? I say that because it used to be that we would put people on very high doses of cyclosporin, and actually before I got into the business, people were on much, much higher doses of cyclosporin. And it turns out that, especially beyond the first year after transplant, patients can be on much lower doses of cyclosporin. There even are strategies to get people off cyclosporin using mycophenolate, Cellcept, and Rapamune, for example. So there are patients who aren't on cyclosporin. There are other patients who just need to be on relatively low doses of Prograf or cyclosporin and don't need to be on anything else. So it turns out that there's actually a lot that we don't need to give, especially beyond the first 6 months, and that we have been over-treating people. Now let me tell you the other reason why we've been over-treating people, and this is kind of like almost a nightmare in terms of like our worst nightmare, not our worst nightmare. So when I was at Temple, I was involved in a clinical trial. It was not a trial, but a study. It was a registry. So what we were doing, and there were 7 other medical centers around the country involved, is we were getting blood samples from people and separating out the white blood cells that cause rejection, and then sending off the white blood cells to a central laboratory where they would look at changes in the genes and when people had rejection versus when they didn't have rejection. So I'll talk about that in a second. The other thing that was done in the study was that everybody got biopsies and we made decisions based on our local pathologist. But there was also every biopsy, every slide was sent to this panel of 3 very eminent pathologists. One was Margaret Billingham, who invented the whole, the 1A, 1B, 3A system. And they all looked at the biopsies and gave their own grade. So here's the bottom line. For patients who had 3A rejections, now called 2R, but 3A, that's the point where we start treating in heart transplant. This panel, looking at these slides, felt that only 40% were really 3As, and the rest were really no significant rejection. So think about that. 60% of the 3As, and these people were treated at their respective medical centers, including ours, weren't 3As at all. And in addition, this very knowledgeable panel, they could only agree amongst themselves about 3A 60% of the time. So the standard of care for making the diagnosis of rejection turns out, at least in heart transplantation, turns out to be very, very subjective. When did biopsy first appear? Biopsy first appeared in the mid-70s. So in the mid-70s, there was no echocardiography. There weren't a lot of the tests that we have now that we take for granted, MRI, CAT scans, PSAs, all those sort of things. And biopsy was done because it used to be that people would just feel sick and then they would drop dead of rejection. So instead, there was an attempt to try to figure out when people were having rejection before they actually became symptomatic and try to treat it. And we've kind of been doing that all along for the past 30 plus years, almost 35 years. But it turns out we've probably been over-treating patients. So where does the future lie? I think the future lies not just in heart transplant. I think it lies in what are called genomic and proteomic tests. And you're probably going to see some of that, those terms thrown around in USA Today and Philadelphia Inquirer, and of course the New Yorker, where that's the medical office. What does that mean? Genomics and proteomics means looking at changes in genes or changes in proteins as a result of certain disease states. Proteomics actually goes back a very long way. If anybody ever had a PSA, I'm asking you males, but anyway, yes, PSA test. So PSA, before the PSA, that's prostatic specific antigen. Before the PSA, if people had urinary symptoms or maybe had an enlarged prostate, they got biopsies. So what the PSA did was it looked at a protein that is produced in excess when patients have prostate cancer. And so that was kind of a screen, though. It doesn't mean if you have an elevated PSA that you have prostate cancer. It just means that if you have an elevated PSA, you should get a biopsy. So as a result of this trial that we did, or this study that we did, we found a whole bunch of genes that changed their expression or their activity with rejection compared to absence of rejection. We were able to develop a test that tells us when the immune system is active and when it's not active. So what does this mean? What it means is that if the test shows that your immune system is not active, you really don't need a biopsy. The likelihood of having a rejection if your immune system is not active is about 1 in 1,000. And remember I told you that rejection, we talk about rejection diagnosed by biopsy, which is in and of itself problematic. If your immune system is active, you're still likely not to have a rejection, but you're more likely to have a rejection than if it isn't active, much more likely. So only in those circumstances would you potentially get a biopsy. So what a number of places around the country, ours was one of the first, but other places doing as well, is replacing biopsies with blood tests. We've pretty much done it in most cases beyond 6 months post-transplant, and are starting to do it within 2 to 6 months. And other places are doing it as well, and I suspect it will continue. And I also suspect there will be other blood tests that will be developed that will look at this as well. In kidney transplant, there's a different set of blood tests that have been developed. One that looks actually at tolerance, one that looks at rejection. One advantage of being a kidney transplant is that you actually have access to fluid that comes out of the kidney, which is urine. So there actually are some tests that look at markers of the activation of the immune system that are in the urine. So there may even be ways of preventing, and of course kidney biopsies are much more difficult than heart biopsies, right? Let's see if that would be here. Yeah. Tranzio, characteristically quiet. Oh, no.
Oh, don't wake him up. Don't wake him up.
Calm before the storm. No, he's not going to shut up. So, where I think things are going to develop, and I don't know which the blood test will be, it probably will be, as with the PSA, it will be refined over the years, but there'll probably be blood tests that we'll be able to use instead of rejection. And they may be able to help us to wean immunosuppression too. And we've actually been doing that with the blood test that's commercially available, which is that we'll cut down the dose of immunosuppression. And if the immune system remains inactive, then we will continue to cut down the dose of immunosuppression. If it becomes active, we'll back off and maybe we'll biopsy at that point. I think those things are starting to happen in kidney transplant. There's active research in lung transplantation looking at another set of genes to see if they can look at, identify people at risk for acute rejection. And then there also are efforts to look at blood tests that may predict some of the other problems that happen in rejection, like the transplant coronary disease or the chronic rejection that occurs in lung transplantation. The other interesting thing is that if you have somebody who chronically has very low scores on these tests, so their immune system is chronically inactive. we're looking into whether that may actually be a predictor of people who are at risk for infection or people who are at risk for developing cancer. Maybe those people don't need to be so immunosuppressed. They need to have some of the immunosuppression cut down and allow their immune system to kind of reach equilibrium. So that's those are the molecular tests. And that leads me to another thing I want to talk about. I'm going to wrap up and then open up for questions, but there's two more topics I want to touch. So one is personalized medicine. I'm sure you've seen this, everybody's seen this in the news somewhere. What does personalized medicine mean? It means that to some degree everybody is different in terms of their response to medications, in terms of their response to transplants. And I think that we are going to be looking at this. These molecular tests are just the beginning. And it's not just in heart transplantation. So, for example, in breast cancer, there are tests now commercially available, a number of them, that look at the tissue that's removed at the time of a breast biopsy. What they can identify is breast cancers that are very aggressive and that require aggressive therapy with radiation therapy and chemotherapy, and then other breast cancers that may, just under the microscope, look the same, but that with these genetic tests are much less aggressive, and so those patients can be watched and don't need go through the rigors of radiation therapy and chemotherapy. And that's being applied clinically as well. In addition, by getting a better sense, in the Human Genome Project, which you've all heard about, has provided people with insight into the genes that we rely upon to function, we may be able to have medications specifically tailored to us. Looking at the response of the immune system in the transplant setting, they tell us which patients respond to certain medicines and don't respond to others, and may allow us to develop even more so sort of individualized immunosuppressive therapy. So that's personalized medicine. Now the final thing I want to talk about is one thing that molecular biology or new medicines or whatever is not going to change, which is the donor shortage. So many of you in this room have been tremendously generous in terms of donating organs, and we on this side certainly thank you for this. But it's been a tremendous frustration in terms of being unable to offer organs to every patient who needs it, and to watch patients who die waiting for transplant. So I'm old enough to remember the days when we actually would have people who would be on milrinone and dobutamine, and they'd get weaker and weaker, and there'd be no organ, and they'd die. For those of you who are at Penn, when I was at Penn, the Daily Pennsylvanian followed one of those patients actually in the early 90s and was chronicling this really terrible story of this guy who died waiting for transplant. And then in the early 90s, left ventricular assist devices became available. Anybody ever have one of those? No? Okay. So these were mechanical devices about the size of a fist that were put in the abdomen, and they took blood out of the heart, and then they pumped it into the rest of the body. These allowed people to survive until transplant became available. So somebody was failing on milrinone, put in one of these devices, and people could live for several months, sometimes up to a year or more, waiting for transplant. It's what's called a bridge to transplant. And then a number of people got the idea that, well, we have a lot of people who aren't really great candidates for transplant, but really have very bad heart function. Why not put these devices in and keep them in? So there was a clinical trial called the REMATCH trial, which looked at this and randomly assigned people who weren't transplant candidates to get these devices or stay on milrinone and dobutamine. And sure enough, people who got the mechanical devices did much, much better. And people who got the milrinone, if they weren't transplant candidates, really did not do very well at all. The problem with the device, this is called HeartMate 1, was that it's a big device, so smaller people can't get it. It's associated with mechanical breakdown, and it also has ball bearings, which apparently cause mechanical breakdown. Cardiologists get to know some engineering, I guess. And also because the surgery is big, and there are some catheters that come out, there's infection that's associated with this as well. So the device was fine as a bridge to transplant in people who were just waiting for transplant and would have it for a few months or maybe a year. But if you're going to put it in somebody and say, okay, you're going to live with this for the rest of your life, not a great idea, because they would get infected, the device would fail. So that was kind of the first bump along the road in terms of trying to find an alternative to transplant. The early device, the HeartMate one, is kind of like a 737. It can fly you from Philadelphia to Chicago, but if you want to fly to Sydney, you're going to need something bigger or more effective. Maybe not necessarily bigger. You need something like that, 777. So there have been a number of new devices that have come out that are much smaller, actually. The one is called the HeartMate 2, which I know they put in the 10 and we put in as well. These devices are the size of a D battery, and they don't have ball bearings. They have continuous rotors. So when you listen to the person's chest, you hear this hum. It's really cool. And they're based on, once again, the airline analogy. They're based on plane engines. They have the same sort of thing as very rapid turning rotors. The devices are small, so the infection rate is small, and the failure rate is low. So these devices are being looked at as what are called destination therapy. In other words, they look at it as bridge to transplant too, and they're approved as bridge to transplant. But they're also being looked at for destination therapy, which means somebody's not a transplant candidate. They get the device put in, and it stays in. We've had a number of people, I know Ken has had a number of people as well, we've had them for several years, and they seem to work very, very well. So this may be what we can offer people who are not transplant candidates, and it may well be, it hasn't happened yet, but it may well be that in a few years there'll be more people each year getting these devices than the 2,500 or 3,000 transplant patients who get heart transplants. So that's kind of where we are with the future at this point. One other interesting thing just about these new devices. So our hearts beat like this. There's the systole and diastole, the upper number, lower number of blood pressure. The old LVADs do the same. They are pulsified. These devices are rotary, so they go with almost 10,000 RPM. So there is no high blood pressure and low blood pressure, just an average blood pressure. So we'd love to have the medical students try to get the blood pressure on these patients. They never get it. But it's very interesting because, if you think about systole and diastole have been around since the days of the earthworm. So they're hundreds of millions of years, and they don't need it. It's very interesting. But there have been people who've had these devices for up to 8 years and have had no ill effects. Very, very interesting. Anyway, that's all I have to say. I have one more thing, because Dr. Franzio has something in the flip. Just talk about rejection. Go back to rejection for a second. So there are two types of rejection. There's the one we always think about, which is cellular rejection, which is caused by the immune cells. There's another one, which for some reason is becoming a little bit more frequent, called antibody-mediated rejection. So in other words, somebody after a transplant, could be heart transplant, kidney transplant, their organ stops working, it doesn't work very well. Setting of heart transplant, they go into heart failure. When we do a biopsy, the biopsy is absolutely normal, at least under the regular stains. And then if you use special stains, you can see antibody on the blood vessel wall. So we don't exactly know how this happens. We don't exactly know how the antibodies cause problems. But the good news is we know how to treat it. So, and it used to be in the early 90s, this was a very feared complication. We didn't know what this was, and we would start doing, just start blasting people. But nowadays what we do is remove antibodies with plasmapheresis, and we also give IVIG, which is a certain kind of antibody that inhibits the cells that cause this. And we can pretty effectively treat this in the vast majority of patients. But that's another type of rejection that's becoming more common and seen in kidney transplants as well. So anyway, thank you for having me, and I'd be happy to open this up, and I know Hal is going to ask the first question. Yes, sir.
Your comments about the rotary devices. How are they powered, and how often do they need to be charged and so forth?
So it's the same thing as they use the same batteries as the pulsatile device. They're powered with the equivalent of 2 VCR batteries, and they each have about 6 to 8 hours of life. So people have to carry charged batteries with them, and they have chargers. But they have this external power pack, fan pack, that has the batteries. That's your husband over there. All right, introduce yourself.
I'm Teresa Rose, one of the heart transplant coordinators at Honda.
I'm Brian Hall, and I'm the assistant director for transplant at Honda.
And I'm Renee Green, one of the
heart failure transplant coordinator. Don't say
Very well. Teresa has been involved for 9.5 years in transplant. And Renee used to work with two companies to work on the heart failure transplant for. And Brian kind of keeps everybody sane. He's kind of another that keeps everybody grounded.
A few words all about Teresa a while ago about who was the coordinator when you were at this hospital, who was the coordinator there, and I went, I don't know, but Teresa has been in Hyman forever. I don't know who's been at the other hospitals, but you can always get Teresa.
Good. Teresa's been there. It's been, actually next month will be 4 years.
Before that, you were
Well, that she was in Temple. But she did tell me the other day, it seems like she's been in Hollywood forever.
Of course, you got patients like me.
I wasn't going to say anything. Keep my mouth. Yes, sir. All right, so do you guys know how generics are, the approval process for generics? Anybody know that? You know this, Art? You know this?
Very vaguely,
So, they don't test it in transplant patients or in the patients who are going to get they test it in 21 patients. And they look at blood levels of the brand name and of the generic, of a generic, one generic. And they have to be within 20% of the brand name, which, you know, for some drugs is probably okay. But, you know, in beta blockers, we don't pay attention to levels or ACE inhibitors. But for transplant drugs, it's absolutely crucial. I mean, 20% can be a big difference. And the other thing is that not all generics are the same. So at least in my experience, the only generic that I think comes close in terms of achieving levels has been January. And the others, when we tried to use them, we would have all sorts of crazy levels. So I think that may be one of the limitations for the program, is just doing the trials to find out. But, you know, I would be, and again, I'm not on the payroll for Stellus or anybody else, but I would at least be very careful in starting people on generics. I know we're going to have to start them because the insurance companies are going to insist upon it. That's fine. I'm very carefully monitoring the levels very frequently.
I'm glad you asked that, because actually the second Tuesday in April, the second chance meeting, there's actually going to be 2 representatives there, one from Astellas and another one from Roche, talking about these generics and what our plans are as far as, you know, going over to generics and what the patients need to know. Yes, that's the second Tuesday of April. That's going to be that meeting. We're going to be talking about generics and what you guys need to know about that.
Now obviously, and you know, people from Roche, people from Stellus were just a little bit nervous about this sort of thing. And you know, Gengraf has ended up being a very good generic form of cyclosporin. So I think that we are going to have good generics, but we may have to find them. And at least from my experience, the other generic cyclosporins have not been great. The other thing, I thought you were going to ask about this, is that there has been some effort to try to develop a once-a-day program, which would be pretty cool, except for some reason it's not been approved yet by the FDA. Stellus tried to get it through the FDA, it wasn't approved. Another company tried to get it, the generic company tried to get it approved, and it wasn't approved. And I think the once-a-day immunosuppressive agent would be pretty good. We're not there yet, but that's probably going to happen. Yes, you could.
No, I'm going to tell you.
Go ahead. Okay. You want me to answer every single question in this thing, right?
No, I the first thing to talk about is the donor awareness.
Okay.
You brought it up, but we've recently seen, and apparently it's something for real, that the donors, people who are actually writing on their cards that they are willing to be donors, as they get older, they're starting to have second thoughts. In their 50s, they start saying, wait a minute, I'm just reading all this about, and it's true, that the doctors are waiting a on the table ready for this organ, and we don't know who's going to have it, and I'm changing my mind. And I think that's probably one of the worst things that has happened on donor awareness in the last few years. I think you know what I'm talking about.
Bernard, could you explain where you're coming from in saying that? Because I've never heard that before. And you just used the word true in your statement that it was true. What's your basis?
All right. One of your articles that I saw right in the drop was simply the idea that more and more this is coming. Same thing happened in the Star Ledger article that I just read, that this is becoming prevalent. That people are now changing their mind because of the idea that this is something now that they're worried about how they're going to be treated on the day.
And where did the Star Ledger reference as their basis? Anything?
I should hopefully say something about it. Yeah, I don't know.
Oh, okay.
Okay?
It's just so different than anything I've ever heard. I'm curious where it's coming from.
That's right. Now, of course we can prove it. However, I'm thinking right now, is it something that we've heard, or is it actual, or?
I mean, I have to say, I've not heard that.
Okay.
Interestingly enough, the one thing I did hear that was very interesting by Penn's bioethicist, Art Kaplan, when he spoke at Connie a few weeks ago, was that if you put on your driver's license that you want to be an organ donor, legally that's all that's needed. You know, we've all thought, well, we have to be through family agreed. And from a legal standpoint, that's not the case. If the donor indicated before they died that this is what they wanted, that's what's legal. And the reason why it isn't done is that the last thing any hospital or any physician would want to have is to get in fights with families about organs. I mean, that would be very foolish. And I think it points to the fact that organ donation is very fragile, that we rely upon making people know that doctors are doing the right thing, and that the right organs are going to be distributed fairly, and also, and this may sound bizarre, but also that nobody is doing anything to try to hasten the death of people so that we can get organs, kind of like coma. And you may kind of say, gee, that's ridiculous, but there was this case in California of a surgeon, a very complicated case, but he was accused of trying to hasten the death of a potential donor. It turned out he was acquitted, which was fortunate, and justifiably acquitted, but I can only imagine if he was convicted, the effect that would have had on organ donation. So it's very fragile, and we are dependent upon the goodwill of the general public. Yes?
That's what the nurse was saying. Our daughter is a 43-year-old oncology nurse, very intelligent woman, a little outside the level. I asked her why. For the very reason that I said, she's afraid on the operating table or in an emergency room, someone will say, that's bad for organs. The whole family knows she would be more than willing to donate, including her husband, and when it comes to that, her husband will say, go ahead, take the organ. She just does not want it in writing. It's her personal feeling.
Yeah, I mean, I think, again, being on the medical side, I can tell you, first of all, if somebody comes to an ER after trauma, I don't think anybody ever looks at the donor card until somebody gets to the point that they're declared brain dead. Yeah, I'm just saying it. So, there are these suspicions out there. And it's interesting that somebody who's in the medical profession, but it really is not. It is not true. Of my patients, I couldn't tell you who signed the donor card or who didn't sign the donor. I have no idea. Yes, sir.
If you came around and looked at what was right in front of you, you give the life donor program. We send people out to schools, at all places, churches, you name it, just to show that this does not happen in terms of doctors and all. we need the heart.
And
It doesn't happen,
Right, and-
especially in Philadelphia.
and you can't, wait, think it happens somewhere else?
Why don't you know Philadelphia?
Doesn't have Philadelphia, New York, I don't know. I mean, and unfortunately, certainly, we all appreciate it. Unfortunately, none of us are ever going to be able to relent because it just has to be, if people relent or give in and say, things seem pretty good and we'll going up, it'll just start going down again because, the suspicions will potentially seep back in. There are suspicions about the medical profession and about organ donation, and so that educational process has to continue. The very best way to do it, it's about 10 years ago, people thought, wouldn't it be great to have Michael Jordan doing this? So Michael Jordan was doing ads on TV, and saw his face on buses, and I thought it was a great idea, except it had no impact on organ donation. And the thing that really does have an impact is either seeing the donor families or recipients or both. I mean, that really has the greatest impact, and much more impact than someone like me going out, because they think that I'm one of the ghouls who will in the middle of the night to take the organ.
The health fair at Harkin College where the medical students, and on the end of the table, two sides, one says, "Are you an organ donor?" and the other side says, "Why not?" And hardly any of these kids had on their license, and they were all talking, and we asked them, "Why don't you have it?" They said, "Well, we heard these stories," and you have to sit there and say, "Who were you with when you heard this? Where were you drinking on Lancaster Avenue? Where you actually heard this news, where you're laying there and somebody needs a kidney, a friend of somebody." And these are people in the medical profession. You have to go back to supervisors of the program and say, "Does anybody do a poll here or spend one time during your program and just talk about this particular part of life extension?" Life extension.
Is there at the present time more than one lab doing Alamo?
There's one that does it. It's in California. They're the ones who developed it, so they're the ones who do it.
What is the one?
Oh, the LMAP is a molecular test. I didn't want to say it because it's a commercial name, but it's a molecular test I talk about for heart transplantation.
One of the things I was wondering, pre- and post-transplantation, you had mentioned the Human Genome Project. If anybody had performed a study to see if people after the transplant may become predisposed to certain diseases from either the medication or from some other outside influence.
Yeah, I mean, I think we do know that happens, and some of these are really unique diseases. So the transplant coronary disease, we call it cardiac allograft vasculopathy, doesn't happen in anybody else. And as to a genetic predisposition, we don't know, except that we know that those people have activated immune system. And then, of course, there are certain kinds of cancers that occur in transplant patients, and not really in anybody else. So the virus that causes mononucleosis, Epstein-Barr virus, when people get mono, this virus invades the B cells. These are the immune cells that produce antibodies. And so if you get a blood test while you have mono, you'll have all these bizarre-looking cells in your blood smear. But then the immunity, the T cells, the cells that regulate immunity, get rid of those cells and the infection goes away. The immunosuppression that we use weakens the T cells. So some people who get either Epstein-Barr virus, the first infection, or activation, get this unique kind of transplant lymphoma, PTLD. So that's another disease that can happen that's unique. Fortunate thing about that is that if you can wean immunosuppression, the disease often melts away, because then the immune system can come back and shut down these cells. And we've actually, other people have actually seen that. In terms of other diseases, there are other diseases that are more common. Some of them are actually side effects of the medicines, so kidney problems, problems with the bones, cataracts. All of these things are more due to the immunosuppression. I wanted to comment on one other thing about sort of letting the public know about organ transplantation. So something from my experience, when I was at Temple, we had a crew from the Discovery Channel following two of our transplant cases around before and after. It's now on the Discovery Channel, and it's been on various different channels. I've seen it in about 5 different languages. So pretty funny seeing me speak Hungarian. The interesting thing about that show was about a year or two after it came out, there was, some of you may remember this actually in Kentucky, there was somebody who shot a bunch of his high school classmates. And one of them, a young woman, donated 7 organs. It turned out she, a few weeks earlier, had watched, she hadn't filled out a donor card, but had watched this thing and said, told her parents, if something bad happens, I want to donate one organ, and they remembered that. So if people see things, they see the benefits of organ transplantation.
To them that, well, they're not on a shelf in a back room someplace for them just to schedule the surgery. So what kind of education do your patients get when they're being listed for transplant?
So, we'll tell them even before they're listed during the transplant evaluation process that, that the organs are not on the shelf, that they're going to have to wait for somebody to die, but that the death is going to happen anyway. And this is the only way to redeem something out of this.
Right.
That we don't know how long it could take, depending upon the blood type. If your blood type AB certainly wouldn't be as long as if your blood type O, but we don't know how long it would take. We also tell them that that they, after transplant, they're trading one disease for another. Because another thing that I remember in the early days of transplant is that people would be surprised that the drugs had side effects, or that they got a teenage heart and suddenly they weren't like they were back in high school. So, we tell them that they're trading one disease for another. They have a fatal disease. That the disease that they're going to get will not be, in most cases, fatal, but there are things that we need to do to prevent that, and they have to take medicines for the rest of their life. And as opposed to the disease that they had beforehand, in our case, heart failure, where if you miss your medicines, usually you just end up getting sick with heart failure and come to the hospital. If you're not compliant with transplant meds, you can die, and die very terribly. So compliance is absolutely crucial. And then the other thing is that there is something called the expanded donor or the marginal donor. Mm-hmm. And so we will tell patients beforehand that we might be considering certain donors, older donors. By older donors, I mean donors in their 40s or even 50s. That we will be considering donors who are hepatitis B positive, but that we know we can prevent the transmission of hepatitis B either by vaccinating patients or also by giving hepatitis B immunoglobulin at the time of transplant and vaccinating again. So we do let people know about that it isn't the way it was 20 years ago, where every donor was 20 or 25, and donors are older and they may have other issues. There have been situations where people have been so sick that we've had to get the heart, and sometimes we found the heart has had a blockage that the surgeon has bypassed at the time of transplant. We let the donor, because the donor gets catheterization before, and we let the recipient know that this is something that's going to be donor. So I think that's the other issue, is also making sure that people know, there's kind of full disclosure about the donor that they're getting.
And just to expand on that a little bit more, as a coordinator, and you can talk to some of our patients here who have been recently transplanted, they will tell you that the coordinators come in and we hold an hour educational session that goes over the things that are going to happen as part as being a patient going through an eval, what they can expect. And on top of it, most centers now have a consent that the patient must sign that goes over all this detailed information about the quality of the donors, what the center is going to be telling them about, and about the handbook that they're going to get that also goes over the eval process. So not only do they hear it from the coordinator while the family is there, they also get a piece of documents that they keep for their records, as well as we keep for our records of the consent that goes over this information as well. And like I said, anybody who transplant patients will tell you that this is a conversation that the coordinators have with them before they even go on the list.
Don't forget that the second chance group is available as well. And that's very important because, like ourselves, we can talk to others that are going to go through the same thing. And if there's anything that anybody really can face the idea of talking to somebody who's already done.
Bernard, the question, and maybe you could answer this from your second chance experience, how often does second chance talk to the patient about the fact that there is a donor on the other side of this situation? That was the question.
Yeah. I think it's all part and parcel.
So the answer is no.
No,
Right.
well, first of all, you look for verifiable truth, which I understand, and I agree. Anything that has to be
The only reason I'm saying that is because I think our chapter is guilty too.
Really?
We never bring that up. And the question was addressing that, and I'm realizing we're missing a piece of the story.
then probably realize that should be addressed.
Yeah.
You know, I think one reason why it isn't is because there's been a very scrupulous effort by people on transplant team to not be in any way involved in potential donors, even within the same hospital. So, give an example. At one point, years back, before we had LVAD, there was a young woman who was dying of heart failure, really doing very poorly, and then a nurse in the ICU, the CCU, came up to me and said, you know, there's a patient downstairs who sounds like they should be a donor. I just heard from another nurse. You know, I kind of told her, these are the steps you need to do. Family has to agree, and call Gift of Life, and please don't talk to me about it again, because I can't in any way do that, including doing the cardiology consult, and fortunately that person ended up being a donor that saved this woman's life. But there's been a very scrupulous effort to try to not be involved. Not everybody agrees with that. In fact, our chaplain, the ethicist, said, well, why shouldn't you be involved in it? You know, I kind of have mixed thoughts. I think part of the reason is if we see a scene coming down saying, hi, I'm a transplant cardiologist, I take care of transplant patients, I'm evaluating your dad as a potential donor for one of my patients, that sounds like a conflict of interest. And really, people who do the evaluation, led by Gift of Life, should be, you know, really dispassionate.
How do you feel about ethicists, like our chaplain?
I think that they're very helpful in terms of directing our thoughts. And I have to say, our chaplain is, there's another reason why I like our chaplain. I'll tell you that too. So, another anecdote. So back in the Temple days, in the early 90s, there was a young man who came in, he was very, very sick. He didn't speak any English. But we had a Spanish-speaking cardiologist, Dr. Pina, Dr. Pina, and a Spanish-speaking coordinator. So, you know, we thought we had the whole history, and a lovely family. He was blood type AB, so he got transplanted a few days after we listed him. And the only thing that was a little puzzling about this guy, who was from a an underprivileged background, was that he had a laptop, and back then nobody had laptops. Didn't know what that meant, but didn't really pay attention to it. And then a few months later, the guy is in for his visit, and the federal marshals show up. And so they go to the cath lab because they hear he's being biopsied. They rough everybody up down there. He's not down there, so they come up to the third floor, rough us up, and arrest him. So it turns out the guy, and one person had made a comment. You know, the guy was in the Dominican Republic, but he must be a drug dealer. And we said that is so politically incorrect. But the guy worked for a gang and killed drug dealers, privately. So in any event, and he was in New York, and he was on trial, and then the judge dismissed the trial because the guy was critically ill from heart failure, was going to die. He moved to Philly. He saw he got sick. He saw a local doctor who knew any history, sent him to us. The rest was history. The guy got transplanted, and of course, it was in the news. Some of our competitors were saying, you know, these people at Temple are the criminals for putting a heart in. And then our chaplain had this editorial, which I still have. I have it framed. He said, the doctors at Temple were right. And what he said was, look, even if they knew he was a criminal, they had to transplant him. I mean, we are not the ones to judge. I'm not so sure exactly why that sort of thing. And while I was on vacation, Dateline came down. Remember, Jane Foley and Stone Phillips, they came down, they interviewed the rest of the team. And when I got back, it was on TV. And, you know, the team did a great job. But the surgeon said, look, you know, I don't think we would have transplanted him if he had been a criminal. Dr. Kaplan said, and I can see what is saying, is that, look, you can't, pass those sort of judgments. So I like him because he wrote his theories for us, but I do think they tell us kind of the right thing. One thing that Dr. Kaplan said, which is interesting, is that maybe one of the ways of increasing the number of organs is to do what they do in the two countries in Europe that probably have the highest rate of organ donation. Anybody know what's in Spain? One, and the other one's Austria. Yeah, and you always wonder, Austria, Germany, you always wonder. Presumed consent. So, want to talk about presumed consent is?
Yeah. An assumption that you are a donor unless you actively make an effort to say no in writing.
So this has to be in writing. I mean, if you said to your family member, I don't ever want to be an organ donor, that would be so. But what they do in Spain, what they do in Austria is that if you never voice this, that they do have, you can say on your donor card that you want to be an organ donor, but if you don't do that, it doesn't rule you out. And as long as you never voice the opinion or wrote it down somewhere that you don't want to be an organ donor, they will take your organ.
Do they need family consent for this?
They do not need family consent for that.
I got to add to that. I've been following that very closely over the years. Spain, with presumed consent, always checks with the family first, and they will honor the family's wishes.
Really?
That is according to record.
Yeah,
It's interesting because here, Gift of Life is in a state, they cover 3 states that have laws that protect your decision to say you want to be an organ donor. But they will, as you mentioned before, always respect the family's wishes because of the potential danger. So they break the law in order to do that. And there's 37 states now that have in their law protecting that right. And there's somebody who keeps a scorecard of the OPOs, and they give a black mark to this OPO because they respect the family's wishes, not the decedent's. That's just some facts, Ed.
Yeah, although despite that, Gift of Life does pretty well, considering that they don't. But in the Spanish law, it's you don't have to do that. So they're just afraid of the same thing.
Yeah.
But even with that, they have the highest rate of organ donation in the world.
The best way I can figure it out from what I've studied is the process they went through to institute that so educated the public that that's what made the biggest difference. And so they still respect the family's wishes, but so many people now understand that there's a bigger commitment despite that. And it wasn't just put in law, and it was like 6-7 years of educating the public before they
the Austrian one, just so you know, comes out of a different. So in Austria, in the days of the Austro-Hungarian Empire, to explain to me by the Austrian surgeons and cardiologists I know, they had a presumed consent for autopsy, so that everybody who died would get an autopsy, unless you said, yeah, I don't ever want to get an autopsy. Everybody would get it. That's still the case. And so this was just extended to, well, these people are dead, but we're not going to do an autopsy until after we remove their organs. So it kind of developed from an old Austro-Hungarian law.
Well, I heard...
Our chaplain actually feels that that's the way to go in this country. At least that's what he told us, was to try to develop support for presumed consent, which may be the best way.
Out in St. Louis, we heard a presentation of somebody who had quite a bit of background to it also, and he said that one of the issues, I think it was in England, is that was the criminals that they were given to science for studying an autopsy to use their organs. So that the idea of taking organs out of a body or submitting to that kind of surgery was associated with the criminal side, and so you as non-criminal wouldn't want that to happen. And so it's been a tremendous education, in fact, coming around that for the history. Every country's got a different story.
Yeah, and of course, the Chinese story is, which is where the Chinese will, now they say they're not doing this anymore, the mainland Chinese, not Taiwan, but the Chinese will take organs from prisoners, so there is no consent. There's just, they get executed and have the highest rate of execution or numbers in the world. And they will harvest not the heart, but they'll harvest the kidney.
The other piece of that, which there's a piece of fiction, by the way. Dan just brought this back to me. Your Heart Belongs to Me, which addresses this story in fiction. Okay, but one of the dissident groups in China, they've often found them in prison, and then they use them as prisoners to donate the organs, even though you and I would say, well, why were they imprisoned? And this is a story which is based on that. So it's not just prisoners as we might think about them. It might be a dissident.
is a dissident group, and at least 2-3 years ago, when the American Transplant Conference was in Boston, there were huge demonstrations in front, anti-Chinese, not against American transplant, but to try to raise awareness. So there were these huge demonstrations of members of Falun, anti-Chinese Falun Gong members. A little creepy.
Could you talk a little bit about the allocation process in the United States today is based upon an awful lot of geography because of the time frame heart can be out, and yet we read about some of the preservation advances that are already in place in Europe and are being tested here. What do you see in the future of that, the preservation of the heart longer, changing the allocation system for
Yeah, that's a good point. So, already kidneys and livers, the preservation is much longer, so kidneys can be out for 24 hours. Hearts, really 6 to 8. There is the device you mentioned that's been tested in Europe. It's essentially a box that perfuses the heart. So the heart can be out of the body. They've been looking really not at 24 hours, but at 12 hours. And there have been some studies in the United States. At least the technology that we have at this point is really not there yet. So some of these organs, at least in the presentations at the transplant meetings, some of the organs have been damaged, not to the point where patients die, but the quality of the heart after the transplant has not been what we would have thought to be acceptable. So I think it needs more work at this point. But I do see that happening, that there will be devices that will allow what's called ex vivo or outside the body perfusion. And then that's going to have a very interesting, and I can't predict what the effect will be on organ allocation. If you suddenly can go hours, or you can get an organ from California, it may make it a little bit more equitable in that there might be organs that would otherwise potentially go to waste in California that could be used on the East Coast or vice versa. But we're not there at this point. It's good to see these things being developed, but they're not quite ready for prime time for the heart, at least. The kidneys is a different story.
One of the questions that people were asking before you came in was maybe you would talk a little bit about the survival, long-term survival, in terms of averages. For example, the average for a heart, as an example, is X number of years. That changes in one sense as you exceed those years. Is there some place that you can go that gives you averages based on how long you're out already? Like a life insurance table does.
Yeah,
you're 70, you have so much expectation.
There should be. I've not seen it, but I would imagine there probably is somewhere, but there really should be, and there probably could be, developed from, for example, so it's called the SSRTR database. And that's actually a number that haunts a lot of us. You see this number is about 9 years. It's kind of the half-life of heart transplant.
Can you get my head in the water? I
Of course.
kind of looked at that as if you get the heart transplant, and the hospital is going to, you're well enough to go home. I mean, they try to kick me out 4 times, and I would go back and call them up and say, all these symptoms I have to come home to call you back up. I haven't, I'm still here. But then when you get home, you go to rehab. And rehab, it's not like you hurt your leg. I just had my knee replaced, so I know what they do to that. But you just had an organ replaced. And 3 times a week for 1 hour is not going to turn back the clock. So it's the individual's concern upon himself to take it upon himself to regenerate his body, regenerate his muscles, to get things back no matter what age you are. That's the only way I think you can extend what these averages would be.
Well, the averages, it's important to consider also that the averages are the averages of every single patient who's had a transplant since 1967. And that if you look at the averages or the curves broken down as a function of time, they've actually improved from the 1980s to now. But if you look at where the improvement is, it's all, in terms of survival, it's all in the first 6 months. So why is that? It's because intensive care unit care is much better. We're much better at preventing the infections that cause problems, or preventing, we're better at treating or preventing rejection. So those are the major things that we can prevent that used to cause problems in the first 6 months. And we're actually pretty good at taking care of. We don't see, one thing that we used to see in the 80s and early 90s was something called primary graft failure, where despite your best effort, you put in the heart and it just wouldn't work. Still see it sometimes in kidneys, but with the heart, we don't see that very often. It's very, very unusual. But then if you look at what the slopes of the curves, they're still the same. So in other words, there are problems that are long-term problems that affect organ transplant recipients. Those are the chronic rejection, the kidney failure that can occur as a result of cyclosporin or Prograf, and at least in heart transplantation, transplant coronary disease and lung transplant, they have their own version of disease, and kidney also. So the good news is we're able to prevent, we've been very successful at preventing, reducing the mortality in the first 6 months. And so the next challenge is the long-term management. And I think there are a number of things that we can and have started doing. So one thing is to get people off of, or not off, but we reduce the cyclosporin or Prograf levels to a much lower point than where we used to. We used to accept creatinines in the mid-2s and 3s in people with heart transplantation. That, well, at least we saved your life, your heart's fine. We now know that people with elevated creatinines don't necessarily do as well as people whose creatinine is good. So we're much more aggressive in lowering the cyclosporin and Prograf beyond the first year, and we actually get away with it because people don't really need all that much. In some patients, we actually wean them off of cyclosporin or Prograf because those are the drugs that damage the kidneys and can actually get restoration or improvement in kidney function. And then there's some of these newer agents I mentioned, the mTOR inhibitors that we think, a lot of us think would be very successful at preventing the transplant coronary disease and maybe preventing malignancy. So, I actually am very optimistic when we have patients who are transplanted now that we can tell them that, especially if they get past the first few weeks, that they can live a normal lifespan.
How long are you get to develop?
Well, Rapamune is already out. And one of the reasons why it's not had greater use is because in the early post-transplant period, it prevents wound healing. So it's a difficult drug to use. It's easy to use further out. It also has some side effects as do any of these drugs. And the other drug, as I mentioned, we're waiting to see what happens in Europe. But I do hear that everolimus will probably be approved later in the year by the FDA.
And
That's an mTOR inhibitor. That's the one that we studied and still being studied at our place and other places. But will probably be approved based on the kidney transplant clinical trials, which are further along now than the heart trials. But I think, in an answer, I think that we can, and it's not something that I believe necessarily 10 or 15 years ago, but I think given the advances that we have in more systematic ways of seeing how immunosuppressed people are, that I think that we can promise people, with caveats, we can promise them a normal lifespan, including you.
And that's what I want to finish with.
Okay?
It's also good to have a good doctor. Now, Dr. Eisen and I read the bit all the time, but he's got my life in his hands, and he knows it. And I honestly feel that he's not going to allow anything to happen to you. I honestly believe that.
That's why he gave you a partner.
Well, that's what I'm saying. So, therefore, I'm in pretty good shape. I'm 73. Well, I'll be 73. Normal lifespan, I don't know. I think what's it, 80-something now for the normal male? 76, actually. And it's going to be that way. However, I have somebody in my corner that I have total confidence in and know that he's going to do everything in his power to keep me around. Same thing, though, that has to hear a two-way street. So I have to help him wherever I can and wherever he needs me, and I'll do that.
I appreciate it.
You can't retire. You can never retire.
No.
Yes,
I can't do it.
Ken, go ahead.
Okay.
When people get transplants now, is there a cutoff age as to when you're giving transplant? When you're talking about the normalcy of life after transplant, with younger people, I think people in their 40s or 50s or 30s, they have all these years ahead of them. But if you get a transplant when you're above 65 or 68, does other things affect your life situation other than being adjusted to the heart transplant?
that if you get beyond 65, things that might be significant at an earlier age, but transplant teams might be willing to forego, like significant vascular disease or some lung disease, become more significant